Well, welcome back, everyone, from your brief lunch. And we're about to go into a couple of different lectures. The first from my colleague, Dr. Eliseo Perez-Stable, who is the director of the National Institute of Minority Health and Health Disparities, or NIMHD. So he earned a bachelor's in chemistry and an MD from the University of Miami. He then completed his primary care internal medicine residency and research fellowship training in general internal medicine at UCSF before joining the faculty there as an assistant professor in 1983. So before joining NIMHD, he practiced primary care medicine at UCSF for 37 years, where he followed a panel of about 200 patients. That's a lot of patient load, Eliseo. So he also supervised and taught students and residents in ambulatory care and hospital settings. So Dr. Perez-Stable was elected to the National Academy of Medicine, the National Academy of Sciences in 2001, and to the American Society of Clinical Investigation in 1996. I have to say, it's been truly a pleasure working with Eliseo on many different projects and many different fronts. We've got joint efforts between our two institutes, and most recently, I've joined the executive committee with him for the newly established NIH program on the social determinants of health. So Eliseo, since we have limited time, without further ado, let me turn the virtual podium over to you. And again, thank you for joining us for our council meeting.
Thank you very much, Rick, for that introduction. And yes, 200 patients per half day was our guide, although most would lower it now to 150, given the chronic disease for general internists. So I'm not going to talk about clinical medicine today, and I'm going to share my screen and get these slides up, I hope, if I can remember how to do this. Here we go. Everybody see these okay?
Yes,
We're good? All right, perfect. So let me minimize this over here. So Rick asked me to talk about NIMHD in general and some focus on how we interact around environmental health disparities. I think that there's a lot of overlap and in common. We both have a strong sense of the importance of community engagement, and I think that's one of the messages. We're also both very interested in addressing issues of unequal care, disparities, social injustice in health and health care on our side. And we're now involved in 3 different initiatives: RADx-UP, the Social Determinants of Health Research Coordinating Group, and also the Climate Change and Health initiative that Rick is leading. And let me get started. So I'll start with sort of our standard definitions of populations with health disparities. The first 3 bullets were the groups that were identified by the Congress that formed our center in the year 2000. Keep in mind that racial and ethnic groups in the census may change. They were proposed to change in 2020. That didn't get approved, but that could happen in the future. We define less privileged socioeconomic status or poor people of any race, ethnicity as included in our populations. And then rural residents were part of the original group, and we qualified as underserved. And then in 2016, after a process that started before I arrived at NIH, sexual and gender minorities were declared a population with health disparities for NIH research purposes. So altogether, you can add up, this is probably at least 60% of the US population, if not more. We consider that all of these groups share a social disadvantage that results in part from having been subject to discrimination or racism and being underserved in health care. Missed the E there. Keep in mind, all these are either identity, location, or social economic status related factors and not conditions. So this involves all ages, all conditions, and all settings. And the health outcome that is worse in these populations compared to a reference group is what we define as a health disparity. A second important point that we embrace at NIMHD is that race and ethnicity as a self-identified social construct and socioeconomic status as a measured individual social determinant are really fundamental in determining health or influencing health care, and that they should be routinely measured and considered in all aspects of clinical research or research with humans, as well as clinical care. And then many examples just quickly highlight, predicting life expectancy and mortality. The REGARD study funded by NIH showed that African Americans with the same exact level of blood pressure have almost double the rates of new strokes in middle age compared to their white counterparts. Most chronic diseases we know are more common in poor people, and this is not a consequence of poor behavior or bad behavior. It's really often an interplay of many factors, including structural ones. And then even within a diagnosis such as diabetes, we see outcomes over a 10-year course in the Northern California study, where all minority groups in that study had more diabetes, but all of them also had 30% less heart disease and twice as much end-stage renal disease requiring dialysis. And we don't really know why that is. Similar system, similar care, same diagnosis. So there is, I think, science to be discovered by having these lens of race, ethnicity, and socioeconomic status in mind. What can we do through an equity lens to reduce inequities? What do we know and what do we need to know to do more? I'll start with basics, standardized measures of factors that affect health. So if I just told you that race, ethnicity is important and socioeconomic status is important, then we should, as a field of scientists, agree how to measure those in a reliable and consistent way. Not use your favorite question or how you ask this, or I don't like that name, I like that name. And this is a challenge. In RADx for underserved populations, we have found lots of variable, moderate resistance on some groups on this. We need to emphasize big data and discovery science using big data, not only electronic health records, but also population data that can be linked to other the outcomes, whether it be electronic health records or primary collection of data. And the disparities field has has emphasized data science to a limited extent, and so this is an area of promotion for us. We at NMHT feel we need to be an engine for promoting diversity of the workforce. We are in a crisis. 14% of new medical graduates and 14% of newly minted STEM PhDs in the US come from underrepresented racial and ethnic groups. We make up about a third of the US population today, and that will increase. So that's a huge gap. And it's not just about social justice, it's about better science and better clinical care. So we see that as a primary component of I mentioned community engagement already. We'll come back to this. This is, I think, an essential platform for research that has an opening now to become more established across the agency. And then implementation. We need to implement what we know works. Frequently, we see analyses that the groups that get the least high quality care are the ones that have the biggest impact of the condition, whether it be control of blood pressure, control of diabetes, cancer screening, or other things. NIH has a strategic plan on minority health and health disparities that NMHT led. It's really the first formal one that's published and cleared and approved by Congress. And all the institutes at NIH participated, all have agreed upon reach goals at the end. There was a NIH-wide committee that was involved. It was led by our institute, but definitely it participated on by every institute and center at NIH. So we'll refer to that. It's foundable on the web, but also can be sent as a PDF. So what is our role? What is NIMHD as a smallish institute? We're growing, but we're still in the small category. We developed this plan, and we have a charge to sort of guide the agency on what to do around minority health disparities. Implementation of the plan is one component, but also collaborate with all of our sister institutes and centers to really, take advantage of opportunities that come up that otherwise we wouldn't necessarily be able to initiate. We've talked about definitions. We separated the science part of our efforts from research sustaining categories. So these are things like capacity building. So how do you build infrastructure in minority serving institutions or HBCUs? That's important. We see that as part of our mission, but we call that research sustaining. How do you do more inclusion of diverse participants in clinical studies? NIH is about 30% of participants in all clinical studies are from minority groups. It's been stagnant for the last 5 years. 30% isn't bad. It could be better. And then I mentioned the workforce diversity area. These are what we're calling research sustaining. We want to be able to look at an IC and say, well, there's a gap area. Maybe you could help with this. Many ICs actually have been in the forefront of leading efforts in their area. So this is not a uniform situation across the institutes. But I would say that today, all of the institutes are interested in seeing what else can they do in what area of their strength. We estimated about $3.5 billion was on minority health disparities. This is from the RCDC system. It's reportable to Congress. I think only the staffers look at this, but it matters to the NIH leadership, and it matters to us to have a better sense of what's the science invested in this, and because the system double counts a lot of things, we have to be careful. We're working on better ways of doing this, and as I mentioned, all of the collaborations across NIH, which are really, really important. This is a distribution of the minority health disparities research across the ICs. And this is not hardwired as, but it was the analysis we did as we were finishing the content of the strategic plan. It took well over almost 2 years to get it cleared. You can see, NCI, biggest institute, lots of money, lots of it in research. NIEHS, I think, is here. Certainly substantial investments, most of it in science. And then I'll show a couple of institutes. GMS is exclusively focused on research sustaining. Now they may have some programs that we would call science. And so you can get a flavor of where this is. NIMHD is here. We fund maybe at most, 12, 13, 14% of all of the research on minority health disparities at NIH. Now, there are many other social determinants of health besides race, ethnicity, and socioeconomic status. I list a few categories here, but the important point I want to leave you with here is think of these as individually measured. So things like language proficiency or religiosity. These are health literacy, so important. And also the structural social determinants. A lot of times people think when we mention social determinants, they're only thinking of structural ones: housing, economic opportunity, transportation, healthy food access, criminal justice issues. These are obviously critical, and they're getting a lot of attention recently across the department and all the other operating divisions in HHS. But it's both, really. Working with our sister ICs as well, we developed a web page and the Phoenix Toolkit on social determinants. The link is in the slide. We completed a phase 1 where we say these measures we're vetting and agreeing on. Many of them already existed. We just collected them and reviewed them and put them in there. The Phoenix process calls for a intra-NIH committee that reviews, and then we bring in an expert panel of outsiders who then go over the data. Usually takes them about a year plus, and then propose which measures they would be supportive of us vetting. We're in a phase 2 of it, so we completed one phase. The measures up there are existing. We're in a phase 2 now that just launched in February. We also staff worked on this research framework that may need some tweaking in the near future, but essentially was to transmit or communicate the complexity of the research that we support. all of it human, and not just all behavioral, which is where most of us started, but also include a ton of biology now, given the explosion of information in the last 25 years, and also a lot on the physical built environment. You go back to 1995, the health and built environment literature was very scarce, and it just kind of exploded after that, parallel to other topics. And similarly, importance of the healthcare system. I, as a former primary care doctor, really believe this is a critical laboratory where disparities can be reduced or made worse, especially for that 1/3 or so of adults who need to see a clinician on a regular basis because of a chronic disease. And then across the board, there is no causal direction in this framework. If I was to press to put one, I would say from right to left, my right to left, societal to individual. Although there are many different factors that go into play, and there are probably other components here that need to be considered. So our interaction with the natural environment, with the animal environment, particularly given what happened with COVID. So a program that we are especially proud of and speak at this council is our Centers of Excellence on Environmental Health Disparities Research. This was launched and agreed on before I got to NIH. It was originally a partnership with the Environmental Protection Agency and NAEHS and NIMHD. After the first 5-year cycle sort of was coming to an end, we agreed to renew it. We tried to give it a Center of Excellence label, although that's neither here nor there. And under Rick's leadership, we went ahead and issued the RFA, got some additional support from Child Health, and funded 3 centers. The Research Center at Baylor College of Medicine, that was new, focused on maternal and infant environmental health. An example of some of the research that they do is described here. The Center for Native American Environmental Health, based at the University of New Mexico, which had been working with tribal concerns around particularly the environmental toxins, in a lot of it from mining, but also issues around microplastics in that the Four Corner area. And I did visit the University of New Mexico before the pandemic, and I was very impressed with all the history and the work that they've done in this area. That was competitively renewed. And the third one is a project that we're all keeping a close eye on as a special, the maternal and developmental risks from environmental and social stressors, or MADRES, where the investigators at University of Southern California have really leveraged multiple resources to establish a cohort of women who are pregnant and to study the prenatal environment and social stressors. The most recent renewal focused on the risk of depression, as well as cardiovascular risk factors postpartum. Now, hopefully this audience is aware that maternal morbidity and mortality is also a topic of great interest to us and MHD, and has been of interest at NIH. Other institutes are in the lead of that effort, but this is a great example of work being done that relates to that, that sort of brings together different disciplines in this observational cohort study to evaluate these associations. Most of the women in the study, by the way, are Latina, of Mexican or Central American background. This was a paper from that group, highlighted one of my recent councils at NMHD, about the exposure between daily prenatal exposure to ambient pollutants measured by nitrogen oxide, ozone, and particulate matter, and depression. And frankly, I would not have thought about this association or this as something that would be on a causal pathway. And perhaps, obviously needs more research, but finding, sorry about that. Finding this level of odds ratio with the second trimester based on nitrogen oxide exposure, I think was significant. So it's really, to our knowledge, the first study investigating this in multiple prenatal ambient pollutants and maternal depression. Again, an important topic for multiple NIHs. So we share many common goals. Now, you could say that about any particular two institutes across NIH, but I think as I highlighted at the very beginning with the NIEHS and its origins, I do think that we have a lot of overlap. We have the Centers of Excellence. Dr. Wojcik has been just a wonderful coordinator leader on the Climate Change and Health Initiative. We didn't get what we hoped we were going to get, but we're really well organized and we're poised to advance, and we will move forward with or without extra funding. In that original language, NIMHD and Fogarty International Center were mentioned. And I have really appreciated Dr. Wojcik's efforts in this, and we pulled together quite a nice group of institute directors to move this forward. The Research Coordinating Committee on Social Determinants of Health is being co-chaired by Shannon Zenk and myself, but Rick is very much part of the executive committee, and I think we're just launching that. Be reminded by the issues of environmental justice, the history of how urban development moved. And I spent majority of my life in San Francisco, and they built a freeway, the 101, right through the middle of, guess what, Latino and African American neighborhoods, and essentially separated those communities. Really impacted the cohesion of those communities, because that was where it was convenient to do. Now, they wouldn't dare have done it in Presidio Heights. And in fact, the northern part of San Francisco organizes it. We don't want any freeways here. And at the time when they were going to build freeways everywhere. And the Bayview still does not have a full service grocery store in that neighborhood. So these are important issues, and much also in agricultural areas in California. This model of community engagement as a sustainable research platform is one that we're promoting in our partnership with National Heart Lung Blood Institute around the SEAL initiative and COVID. And then we do share the perspective on RADx. Not necessarily on RADx UP, although we both are working across the board with the whole RADx program, so have a perspective across the board. Let me share some other data. This is differences in life expectancy by county and race ethnicity in the US. This is a analysis we did with the Institute for Health Metric Evaluation, the Global Burden of Disease group at the University of Washington. This will be published next week, I think. And it's looking at county level factors, adjusting for other ones by race ethnicity. So notice that and the way to read this is, if you're in the purple, sort of bluish purple, whatever range, you do better than white Americans. If you're in the yellow brown area, you're doing worse. African Americans generally do worse, but you can see that there are areas that they actually do better at the county level, even in the South, in the Southeast. So this will be important for us to understand what that's about. Similarly, for Hispanics, which generally have a longer life expectancy, look at the Rio Grande Valley down here on the border, and the San Luis Valley in Southeast Colorado, or this area of New Mexico. So to give you a flavor of the kind of work that we're trying to support, this was done in partnership with multiple institutes, as well as the intramural program at NIMHD that really led this contract. This is a collaboration with the National Cancer Institute Population Science Group, and published last year, looking at excess deaths from COVID. And directly, 74% of the excess deaths in 2020 were estimated to be directly from COVID, based on the preliminary cause of death from the death certificates available from the National Center for Health Statistics. Clearly, men do worse than women, or males worse than females, and clearly Latino and Blacks do worse than whites, and American Indians as well. American Indian samples always tricky because of the sample size. Asians, as a very heterogeneous group, are no different than whites in terms of mortality related to COVID. And Native Hawaiian Pacific Islanders weren't separated out from Asians, so we can't really make a statement, although regional data would imply that they suffered similarly. Monica Webb Hooper, the deputy director at Annapolis, scientific director, and I published this viewpoint in JAMA right when the pandemic started. And unfortunately, 2 years later, we haven't really put a big dent into the challenge. You know, there's 2 to 3 times greater risk of cases, hospitalizations, and deaths. We're now settling into a different phase of the pandemic, so we'll see how this sorts out. Higher risk was really related to social conditions, jobs, access, crowded living situations, not able to isolate if you're, 2 families in a home or 3 generations. The expected life expectancy has been estimated up to 3 years loss for Latinos and African Americans. If this holds, that means all of the gains African Americans made from 2000 to 2018 were wiped out in 1 or 2 years. For Latinos, of course, it's coming back closer to whites. We expect that number not to hold, but we'll see how this evolves. And then the issues about vaccine uptake, initially a big challenge with African Americans. I think we made a lot of progress, but we're falling behind again on the 3rd dose. And what we see now is rural Americans and those with less education, particularly among whites, but in general, are least likely to believe in science and at least consider uptake of the vaccine. And I think this is unfortunate, the way things evolved in our country. RADx UP, or the underserved population, is a huge initiative, as big as the NIMHD budget almost over a 2-year period. We have funded 127 projects across the country, from Hawaii to Puerto Rico. So that's, I think, around 7 time zones, or 7-hour time difference. 10 are focused on tribal communities or urban American Indians. They're not exclusively focused on minorities, but that is one of the major targets. There's a school initiative as well, as return to school and stay safe in school. And working with Richard Hodis from the National Institute on Aging, as well as the co-leads who have been spectacular in making this work. This is just, again, a sense of the numbers, 127 unique projects, large coordination and data collection center, our first endeavor with sort of large data repositories, over 112,000 unique participants already consented and tested, with many more individual tests done. Some of the projects are using electronic health record to abstract individual tests, and multiple projects now reporting data to the coordinating center on a regular basis. We had a scientific symposium in May 3rd, and there's going to be a special issue of American Journal of Public Health, I think in a couple of months, with about 10 or so peer-reviewed papers from that. I mentioned SEAL earlier. This has an interesting story. It sort of came out of the efforts to make sure that Moderna's vaccine trial was more diverse than it originally was looking to be. And it was born out of 4 months of Saturday morning meetings with Francis Collins, Tony Fauci, Gary Gibbons, myself, the Surgeon General, and Montse Slaoui, as well as the Moderna CEO and CMO. And it was really a sort of an eye-opening experience in working with them. Of course, they were getting lots of money from the government, so they were more than happy to share and collaborate with us. And they did successfully diversify their studies. So 37% of the final randomized group of over 30,000 participants came from a racial and ethnic group. Originally, they were hovering at less than 10%. And they kind of said, well, we don't know what to do. We've done everything we know. And SEAL didn't help them concretely. It was more the other things that we recommended. But SEAL was established to be responsive to future crisis like this to move the needle on other issues. We're now more focused on vaccine uptake and maintaining information, so addressing misinformation and building trust that can be sustainable with these communities. We're in 21 areas, 21 states. It has primarily had a focus on racial and ethnic groups, but obviously it includes other populations. We've done a lot with communication. There's a great website. Moving at the speed of trust has been our mantra. Really, this has been as much of a full partnership with community organizations as I have been involved with. It wasn't academics or NIH saying, "Oh, here's what we want to do. Let's discuss it, and we have 6 months to figure it out." We started together and figured things out together. So it has perhaps less of the science that I would eventually like it to see include, but it definitely does have the buy-in. There are several hundred community organizations that are affiliated with SEAL in one way or the other. With the SEAL sites, I should say, we centrally are not managing that at all. And we estimate over 2 billion views of our materials at this point, much of it on social media and the web, and NIH produces materials, then gets disseminated to the sites, and then they go ahead and adapt or develop their own, not necessarily use exactly what we have. Let me try to wind down by saying a few things about an unpleasant topic, not polite conversation, which is talk about racism. And these are old data from 2015, the Kaiser Family Foundation survey of Americans, which is a random sample of the US population of adults, asking, in the past 30 days, were you treated unfairly because of racial or ethnic background in a variety of settings? And you can see that 53% of African Americans said yes to this. And this, mind you, was the last 30 days. And over a third of Latinos said yes. So we have a problem when these are the data, and these are the data 7 years ago. Today, I really doubt that we've made significant progress here. What's changed in the last 3 years is now that institutions and organizations at least have acknowledged and aware that this is a problem and are beginning to do something about it. I think the sort of the energy that followed the murder of George Floyd and around social justice issues has waned some, but it is our responsibility to sustain this as much as possible. Now, being at NIH, think about it as research constructs, and these are a list of categories that we use. Most of the work that you know and have read about is interpersonal racism. So everyday discrimination scale, there are other measures. That's the one that's on our Phoenix toolkit. Well, good work done, lots of associations with mental health, substance use, and some cardiovascular and other outcomes that have been established. There are other ways of thinking of this, and I won't go over these in detail. So we have a chance to at least mention structural racism, which is really the big challenge. Initially, when I got to NIH, I wondered, is this really a research construct? Can we study this as research, or is it more of an organizational population construct? And go back to redlining, the so-called redlining. This is a policy of the United States government. The Federal Housing Administration, that records indicate, most US cities were segregated in large part, not because people want to live with people that look like them, not because, oh, that was the culture, the tradition, that's where people live. There were policies to create this that perpetuated this. So type A, highest grade residential property, will control and restrict. This is the District of Columbia, by the way, the Northwest. Type H represents Negro developments in lowest grade east of the river. And what we ended up with is a segregated Washington with differential in life expectancy that exceeds 10 years. And this has been repeatedly done and evaluated in multiple cities in the country. Not all cities have been impacted in this same way. Out west, there's It's somewhat attenuated because of the nature of the population, but this is an important topic for us. We held a scientific workshop in 2017 on this topic. We said, well, it is a research construct. We'll move forward with it gradually. We funded a special issue in Ethnicity and Disease that coincidentally was published in 2020, so it was good timing for the outcome. We also wrote a RFA for this. We got a robust response. I think all the institutes signed up. And NIMHD will be funding probably about 8 or so R01s on this. I think the awards aren't yet been made, so that's all I can say at this moment. And then the Common Fund program cleared a big concept called COMPASS, the Community Partnership to Advance Science for Society, that I'm one of the co-chairs. $400 million commitment over 10 years. And we're in the planning phase now, although it was presented at the Council of Councils in January, so you can access the public documents there. I think we're adhering to that sort of master plan, although of course all the details are being worked out. This is a notion of the master plan, and I will just say one thing that's really transformational about this idea is that these community-driven health equity structural interventions will be funding community organizations, not academic research units. We will have academics involved in them. We encourage that and expect that in the applications. At the same time, we'll also fund a coordinating center and scientific research hubs to provide more support to the community-driven structural interventions. Lots of examples of the kinds of things that potentially could work. We're also discussing potential linkages to other agencies in government. Some of you may be familiar with the Moving to Opportunities study. It was a house and urban development project that NIH helped co-fund, showing an interesting set of outcomes. I think those kinds of thinking about this is just a variety of examples of different structural interventions. Perhaps things like the junk food taxes or the sweetened beverage taxes have been popular in some communities at different levels. Let me finish up by, again, reemphasizing the importance of community engaged research. I think this idea of equal partnership among community organizations, scientists, and then other sectors. What is a community organization? Believe it or not, I think that's not all. I mean, rather than say, well, it's anything not academic. Well, not exactly. We do want people with real grassroots connection, and there may be some academic institutions that do, really are very connected to their community. So it's not so easy all the time. We need to recognize the importance of health and well-being, and not just health care. We have the best healthcare system in the world for people with severe disease and rare diseases. One of my colleagues in public health science said it's like in football and soccer, that is, we have the absolute best goalie because we really are incredible at defending that with the healthcare system. But that's only one player out of 11, and we really need to worry about health. I'm a strong endorser of the model of healthcare to move to sort of population health, make systems responsible for populations, build it on a strong development of primary care and secondary care specialties that account for the vast majority of health needs of the population. At the same time that we need to build healthy communities. People need to be able to access healthy foods at affordable price. People need to feel safe in their community from all kinds of criminal activity where their quality of life is impacted if they're afraid to walk out. And then we also need to acknowledge and manage issues around structural racism. A plug for the NIMHD Health Disparities Research Institute. It's a week-long seminar that we have in the summer. We've had 332 participants over 6 years. About 60% are from underrepresented racial and ethnic groups. About 20% are physicians. It's really a networking opportunity. They get to learn more about what NIH is like. They do have to submit some ideas, research, and make at least a commitment to write a grant in the next year, whether a K or most of them are still in the pre-K phase, although occasionally we'll get someone a little bit more advanced. And then we have lots of different kind of funding opportunities at NIMHD. One of my recent retired staff said, well, maybe we should slow down. People are working too hard. But it's really hard to pause, right? In this, when it takes a year to see these come to light, and it takes 5 years to get results. So some of the more successful ones have been like social epigenomics on etiological issues, mechanistic issues. We've also had all of these have had good responses. Some of the newer ones are related to innovative models of care of patients with multiple chronic diseases. We've raised our budget cap for that. We had a recent one that's a more of an urgent one on addressing health misinformation prompted by the COVID crisis, but not limited to COVID. So I'll stop there. Have my email on the program, and hopefully I didn't take too long. Thank you, Rick, for the opportunity.
Eliseo, again, thank you. And you actually have another 30 seconds. So perfect timing. And actually, we're going to go into now a presentation by Mr. Arsenio Mataka. And then, Eliseo, I hope you'll be able to stick around. We're going to kind of open it up for a discussion with our council.
I'm staying for the.
Okay, terrific. Great. Okay, Arsenio, I see that you are on. So if I can just take a minute, I will do an introduction, a brief introduction, and then I'll turn it over to you. So Arsenio, can everyone hear me okay? I just want to make sure that I'm coming through.
Yes, we can hear you.
I think so. Okay, great. So Mr. Arsenio Mataka is the Senior Advisor on Climate Change and Health Equity, and he's reporting into the Assistant Secretary for Health. So previously, he advised Xavier Becerra, who was at the time the Attorney General for California, and he advised Xavier Becerra on environmental policy and law. So prior to joining the California Department of Justice, Arsenio served as the special advisor to California Governor Jerry Brown, specifically to help craft climate change legislation. He also served as Assistant Secretary for Environmental Justice and Tribal Affairs at the California Environmental Protection Agency, and he did this from 2011 to 2017. So Arsenio graduated from Sacramento State University with a bachelor's degree and went on to receive his law degree from Humphreys College School of Law. So without further ado, Arsenio, let me turn the virtual platform over to you, and thank you for joining us today.
Great, real quick, thank you for having me. It's a pleasure to speak to the council. As hopefully my presentation illustrates, I think some of the work that has already been done in NAEHS is some of the work that drew me to come here to HHS specifically. And so what I wanted to do is start off with a little bit about myself to give you a sense of where I'm coming from, and then move into some of the work that we anticipate here at HHS with respect to environmental justice. So this is my story real quick, my abbreviated story of living with pollution. Next slide, please. So this is where I'm from in California. It's in the rural part of California, and California's Great Central Valley. And these are my folks, and I come from actually 4 generations of environmental justice advocates. My grandmother, my parents, myself, and some of my nieces and nephews have all been involved in environmental justice matters. Those are my folks. And the last photo is actually of the top is my brother, and I'm on the bottom. And this article, this book that was just written by Dr. Tracy Perkins on environmental justice in California, there's a chapter dedicated to this sort of family that is working on the inside of government, on the outside of government on environmental justice. And that's a photo of the page of one of the chapters. Next slide, please. So I want to give you a sense, this is my town, a little more granular look at my the town that I grew up in. It's a small farm worker town, but at an early age, I noticed that my folks who as I mentioned, we're environmental justice advocates. We're constantly trying to get the attention of those in power about, and these are elected representatives usually, about some of the issues that they felt, environmental issues that were affecting the health of our families and, you know, their children and me. And so I always start by saying that, you know, up to the upper left-hand corner, at one point, we had the largest tire pile in the world close to our community. And actually, we were burning those tires for electricity. And not too far down the road, we had now, which is one of two trash incinerators, where we would take the regional, all the waste from the region and burn it again for electricity. We were home to like the regional landfill. These are common things that I think many environmental justice communities face. For me, you know, personally, my folks got involved with pesticides, and actually my mother was able to achieve one of the state's first buffers around schools with respect to pesticides, because it was common that when I was out on recess, the crop dusters would be spraying to an adjacent field. As you can see, the fields are right next to homes and schools. And, you know, on top of that, we never, to this day, I just went back home last week and we still cannot drink our water due to high nitrate levels. And that's been an ongoing battle, of which we've had some victories, but still not really perfect. And finally, if you go down to the bottom, the rankings typically of this area of California is among the worst in the nation when it comes to ozone and PM 2.5 pollution. And as you can see, you know, there's a little green area around my town, and that's the San Joaquin River. And what a beautiful asset, but for most of my life, that was closed off. And so while you live next to this, you know, great wildlife conservation, you know, kind of river, you felt disconnected to it. So next slide, please. So, but of course, my community isn't, you know, unique in that nature. All throughout the nation, there are many communities that suffer similar cumulative impacts. And I just thought, you know, I would highlight a few to give you a sense of, you know, and many of you are aware of this, but to show that, you know, in some cases it's rural California, in some cases it's other areas like this part of North Denver, where we know when you look at environmental exposures, health vulnerability, and social vulnerability together, these areas like really pop as like some of the highest in the nation. And these are some of the underlying sort of reasons for that. Next slide, please. And, you know, and here's a really good example of where when you take the totality of these cumulative impacts, places like Butte, Montana, show up as just as high as some of the more conventional areas that you would think of when you talk about environmental justice. And I'm talking about cumulative impacts because, and I should have mentioned this before, because as I referred to my folks going to decision makers at the dais, local, you know, elected officials, state officials that I would eventually then go and be one of those officials in state government, they would commonly be told, you know, you don't have it worse off than anybody else. You're not a scientist. You have no data to show that, you know, your concerns are, you know, just anecdotal, you know, they were dismissed, ignored, belittled. And in certain areas, some of which I just highlighted, you know, there's not a, you know, strong academic institution presence. There's low, you know, maybe community-based organization capacity, research capacity. And so you kind of felt like you're on your own, you know. And what I didn't add in here is that this sort of problem led to one of my first sort of projects at California, which was the development of a cumulative impact screening tool called CalEnviroScreen, to answer the question for my parents and others who who seem to not have anybody help them with this idea of what do all these environmental exposures and vulnerabilities added up look like, and how do I compare to the rest of my rest of the people in California, and in this case in the nation. Next slide, please. And this is Salt Lake City. For those of you familiar with Salt Lake City, that wouldn't surprise you. But for me, coming from California, this was, very interesting to see this area really pop when it comes to cumulative impacts. Next slide. San Bernardino. Now, San Bernardino, this is an area when we think of COVID and the pandemic, and we think of supply chain, and you think about all the work by the administration and business to really push that the movement of goods and product to get to the right places. 50% of the goods come to this area of California from the ports of LA and the ports of Long Beach, put on trucks, cargo, to San Bernardino, to these warehouses, and then shipped out to the rest of the world, to the nation. And so it wouldn't surprise you that there's these extremely high indicators and cumulative impacts, as well as other types of health issues. Next slide. And then, of course, Detroit, of which, is not in Detroit proper in the city core, but an area sandwich, which looks to be like between an airport and some heavy industrial areas, have other challenges. And so, next slide. So that brings us to environmental justice, inside the federal government. And given, the state of affairs that are unique in many communities, but in some cases the same, what are we going to do as a federal government for environmental justice under the Biden administration? Next slide, please. And so, I always pose this question because I think it's always important to at least acknowledge what is currently existing. And it's just the truth of the matter. And as the secretary just said in a statement last week, this is the blunt truth that certain communities are catching still hell from a lot of these environmental impacts that are impacting their health. And what are we as a Department of Health and Human Services going to do about that? Next slide. So this was Executive Order 14008. The president signed this a few days after he was sworn in. And a lot of it gets focused on climate. But in 14008, the president is directing all agencies, federal agencies, to make achieving environmental justice part of its mission by developing programs, policies, and activities. So a lot of times people overlook that sort of provision of executive order. But I thought we utilized this at OASH, at the Office of the Assistant Secretary of Health, to sort of establish an Office of Environmental Justice. Next slide, please. But before I get to that, I have my slides a little bit transposed. I wanted to talk about a project at NAEHS, which many of you may be familiar with, that was funded through NAEHS. And the slide's a little bit off here, but this was a project that looked early on. It must have been maybe even a decade ago, where NAEHS came in and funded this air monitoring project. And it was, didn't happen by accident. You all had a program that really looked to fund research that really built projects with the community and not just for the community. And it was a consortium of, academics, of local officials and community residents that built this air monitoring project. And it was highly needed because the picture of air pollution was inaccurate and incomplete in this region and many regions, really. There were very few regulatory air monitors. I was at the state agency at the time that was responsible for the air regulatory monitors, and we knew the community knew like my parents, they knew that that picture was incomplete and that they were experiencing maybe local pollution that wasn't being picked up by these very expensive regulatory monitors that modeled out, environmental data, but really did not a good job of picking up local air pollution impacts. Thanks, Liam. Liam just put that in the chat. Can you go back real quick? And the reason why I wanted to post this slide is because as we look at infusing environmental justice into our programs, our policies and activities, as the executive order said, this was doing it well before that executive order. Elements of public participation, and not just for the sake of it, this project, and I can say this because I was there in California, it transformed air pollution advocacy and policymaking in California. It led the way for a proliferation of low-cost air monitoring sensors that really changed the game as to how we would go about thinking about air pollution for California, and at a California Air Resources Board that is supposed to be one of the best in the world. And this little project, I was in a room when they showed the data from these air monitors up against our regulatory band monitors, and they're showing how well they were doing and how highly correlated they were on the data. And our folks, acknowledge that this is really good data, and it's going to really change how we look at air pollution. I had a chance to actually write a law. It's the first law we believe in the nation that looks like to regulate air pollution at a local level, and that would not have been possible if these air sensor projects hadn't tried and tested and proven that this information could be valuable in even a regulatory process and law. And so I can't tell you how much that one project led to a transformation, and that now is going across the nation. Of course, this is much more prevalent, but these are the types of things, projects, programs that we'll be looking to advance as we develop a new Office of Environmental Justice, which is the next slide, please. And so last week, we established an Office of Environmental Justice here at HHS. It's within the Office of the Assistant Secretary for Health. It utilizes the sort of requirements out of the executive order 14008 and tries to put together a dedicated team solely focused on environmental justice. And so we're excited to get that up and running just last week. Next slide, please. And here are a few things I think we'll be working on. And I apologize for the formatting. This is my other program that's doing this. So people always ask, okay, what are you guys going to do? The first thing we're going to do is we're going to put together a strategy that has action items in it. And so we will be looking to NIH broadly, as well as NAEHS for concrete sort of actions that can be taken in the spirit of 14008 as you look to incorporate environmental justice into your programs and activities. We'll be putting together a strategy and an action list for the department. Next slide. And as somebody put, there is a request for information out of where we're gathering public input on that. The second is we're working with CDC to put together an environmental justice index. And actually, we're really close to that already. We've been working on that well before the office was in place. And based on my experience in California, having data and tools to help people understand and focus and prioritize was an important barrier that we had to sort of jump over in California. And when you're introducing environmental justice, some people have a very high understanding of it, some people don't. And so sometimes information like this helps people think about environmental justice in a different way, and it may be helpful in their programs or activities. And so we hope to be working with CDC to release this probably in early July. And to our knowledge, it will be the first cumulative environmental justice screening tool in the nation for the nation. Now, there's others at EPA that look at these indicators in silos, but nobody kind of puts it together. And that's what we're hoping to do. That's one of our priorities. Next slide. Of course, I don't have a lot of time to get into this, but the administration has this big Justice 40 initiative that basically says 40% of certain investments that come from the infrastructure bill are to be going to environmental justice communities. They have their own screening tool that looks at how to prioritize that, as well as other guidance. But we're kind of serving as that hub for those programs that have been tagged as a priority for Justice 40. And we'll be hoping to facilitate the conversation between the White House, CEQ, OMB, and the programs here at HHS. Next slide. This is a really important one. We're supporting civil rights investigations. We currently have a joint investigation with the Office of Civil Rights in Alabama, Lowndes County, where despite every politician, every agency known to this country going down there and looking at the problem, raw sewage still persists throughout the large parts of the county. I wouldn't say majority, but damn near it. And we have an investigation to see if the raw sewage and the impacts to public health, and whether or not the state of Alabama has violated and has acted in a discriminatory manner. And so we provide environmental justice expertise to that investigation. I spent a week down in Alabama a few months ago. I'm looking at that. And so here's an example of using enforcement sort of tools to sort of achieve some justice, environmental justice. Next slide. That's it. This is my usually 5 tips for environmental justice, for usually like a lot of other program folks or people who are trying to sort of expand. And I feel like I'm preaching to the choir here with NAEHS because you all do a very good job. Liam, some of the research action projects, I actually go to those meetings and I hear and learn about some of that. So you guys are already implementing a lot of this, but for those who are looking or are on that are looking to expand on environmental justice, I give these 5 tips. Next slide. Let's work with intentionality. I think if we're going to address environmental justice, you have to name it. You have to set aside the people to work on it. We can't just say this is something that everybody, is infused with or is part of all of our work. You need to be able to name it. Somebody needs to be held accountable to actually work on it. You need to show that you're prioritizing environmental justice in some way. Using tools like I mentioned before may be a good way to do that, or specific programs like NIAHS had that actually probably do a really good job of prioritizing an EJ in that grant program. This is the rule of 3. My rule of 3 is when you're working with communities that you do 3 things before you ask them a favor. That's just an organizing sort of method. And then here, finding the merging lane. It's really seeing, we could do things in government that we think are helpful and impactful to communities. But I always find the best government work we can do is when, our lane merges with people who are identifying community level problems. And we are in some cases flanking them or sort of assisting that towards that same goal. I think when you can find that merging lane, you hit the sweet spot. And then just respect for these communities. It's a serious issue here at the environmental justice. As I said, if you go down to Lowndes County and you have to just muddle through raw sewage and folks and think that that's acceptable, you have to respect the folks who continue to fight. And it's not by accident. The area of Lowndes County is right between Selma, Alabama and Montgomery, right between the march from MLK. With that same path. This is where this injustice lives. And so it doesn't surprise me that those folks are resilient and still keeping faith, but you have to respect them for, the sort of impacts they are facing and the seriousness of those impacts. So that's my quick run, Rick. I think that's it. I'd be happy to stick around for a little bit. I know Eliseo is still there too. But that's a quick run, and happy to answer any questions or discussion or however you guys want to do it.
Arsenio, terrific. Well, it's good that you can stick around for a few minutes because we'd like to open the discussion with our council and others that are present on the Zoom. But before we do that, I want to introduce the facilitator for that discussion, Dr. Michelle Bennett. As many of you heard from me during my presentation yesterday, Michelle is currently the Senior Advisor to the Director here in the Office of the Director at NAEHS. And her function is to provide oversight for the strategic initiatives at NAEHS. So she works with scientists from across our institute and across the NIH. And the purpose is to catalyze the identification of new strategic research opportunities and partnerships. And amongst many of her skill sets is the ability to provide really super excellent facilitation of discussions. So we've asked her to step in today and to facilitate the open discussion with our two speakers and with other members of council. So Michelle, let me turn the virtual podium over to you.
Oh, well, thank you, Rick, very much. And good afternoon to everybody, the council, the Zoom participants, and those people who are viewing. So it really is always a pleasure to be asked to moderate or facilitate. And I would just say that both Eliseo and Arsenio, your talks were incredibly powerful and inspiring. And so thank you so much. So I recognize two things. Rick said I'm a good facilitator, and I appreciate that. My secret to facilitation is to let everybody else do the talking. And so that's part of what I will be doing. And I also recognize this is the last session of 2 days of council. And I just want to let everybody know that we've saved the best for last. So I think this will be a fantastic discussion. I'm really excited. So we want to provide you, everybody who's our council members now, an opportunity to help us, NAEHS, think about what we should be considering now so that in 5 to 10 years, we're making the progress needed. And I think on the heels of Arsenio, when Arsenio comes and knocks on our door and says, hey, what do you have for us? What can we do to make progress? We'll have some ready answers. So we've put together a few questions to spark the conversation. And of course, these are not the only questions. And so we're looking to you to raise other topics, share opportunities that you see. And of course, Eliseo and Arsenio, we're looking to you to continue to share and or provide input to us. So the slide is up, and what I'd like to try to do is I would like to read the questions just quickly, and then I'm going to do my best to copy them and put them in the chat so we could take the slide down so that we can see each other. So let me just read through the questions. So what is needed to advance the science of measuring structural racism and discrimination in environmental health science? The second one is, how can the science of structural level interventions that target the upstream factors that contribute to environmental health disparities be advanced? How can we successfully integrate social determinants of health and principles of environmental justice into how we assess exposure impact, especially in the context of exposomics and precision environmental health? Recognizing the multi-sectoral nature of these EHD, EJ issues, who are other partners that NAEHS should work with to advance efforts to understand and address environmental health disparities and bring about health equity? And so, as I said, I'm going to work to put these into the chat box so that we can take the slide down, and you can look at the chat box and you'll remember the questions. Can everybody see the questions in the chat box? And with that, I would like to open up the floor for comments, discussion, etc. Karen, you're speedy.
Yeah, it's fast. Actually, so I had sort of one of the questions that your last question is something that I sort of wanted to ask about. I don't have any really suggestions, but more questions. First of all, the two presentations, Arsenio and Eliseo, they were really very enlightening. Depressing in a way that there are so many issues, right? But I guess my question is, what role, this is in thinking about prioritization. So there's way too much to do, right? And there's not enough funds. It always comes down to money, I guess. to clean everything up and to take care of all of the inequities, right? So how, number one, who and how do we prioritize? And number two, so there must be local, state, federal, et cetera, entities involved in all of this, policy making and funding. How does NAEHS fit into that? So how much can they advocate for these various, whatever we may put as priorities, and how do you prioritize? I mean, so many people are in desperate need. So that's a really tough question to answer, I think, but I would just like some more information so I have a better idea of the role of NAEHS, for example, in the whole process.
So Karen, before we go on and before Eliseo and Arsenio respond, would you mind introducing yourself? So I'll ask council members, when you ask the first question, just give well, you can see your name, but a little background so that they get to know you a little bit.
Sure. Karen Vasquez. I am at the University of Texas at Austin. I'm a professor and division head of pharmacology toxicology, and I am a council member.
Terrific. Great questions.
Two quick thoughts from me. By the way, Karen, I'm headed to Texas because in San Marcos, Texas, the same issue in Lowndes County is where you have this community full of raw sewage and issue. I would say those are the reasons why I put up my slides. So for the reason for the cumulative impact slides is to say, eventually we will have this tool that can help us look at like somewhat objectively as to like where are the places, and from a place-based perspective, not a population-based or a, but a place-based perspective, where we may want to sort of prioritize our efforts. If you start in the 100th percentile in that tool, probably not a bad place to start. And so that's why I mentioned like using these tools to just like, as you said, it's wide open. I could, throw a dart and, something there, but at least that you would be, depending on what you have to bring to the table, you could see, okay, this is a community. It's in the 100th percentile for asthma. It's in the 100th percentile for toxics. It's in the 100th percentile of social vulnerability. Clearly a lot of things. This may be a good place to start if my program can address any of those issues. So the tool I put in there, the cumulative impact screens for that. It's one way to think about prioritization. There are probably many others. The second thing I would say is that the project on the environmental monitoring project in Imperial Valley, there's a good example to where you're right. NAEHS did not have control over the air regulatory monitoring system. They did not have control over local decisions or even state decisions, but they were able to put into play information that impacted all those streams. And I didn't even mention one where on one of these locations at a school, they did something as simple as an idling bus that was co-located next to a playground, and the PM was really, really high. And they just decided to move the drop-off point and the PM for the playground. Very simple, really small thing done at a very micro local level with information that NAEHS helped provide. So, you can't, you're not going to be able to, wield your way into strong arming your way into those things. But if you could think strategically about those types of projects, that changed the game in air monitoring in California and probably the nation, that project. And so those are two things those are reasons why I had those slides up, because those are two things for prioritization and for impact that you could maybe think about as examples.
Yeah, thank you. Well, thank you again for all of your efforts in this area, both of you. It's really fantastic, impressive. Like I said, a little depressing, but we're moving forward in the right direction. So thank you.
Alicia, do you have? Yeah.
I'll just add a comment. I think we need to really actively break silos and think of a whole, how we can collaborate. You asked about other partners. I can think of housing, obviously transportation, and then also healthcare. The clinicians have often, we stayed within the constraints of the hospital, the clinic. And I think more and more understand that people are out in the community most of the time. So we need to also worry about the community. If they're living in an environment where they're exposed to raw sewage or toxic environment, or have no access to healthy food, that matters to us. So this is leveraging, at least three other agencies or divisions in the department. So I think those are the kinds of partnerships that we do that at NIH. We've been doing that at NIH for some time and do more of it, but I think we need to reach out across other sectors. And I'm optimistic that Compass will lay a foundation for that. We'll see how it evolves. So
Thank you. Very informative.
Phil, you have your hand up.
Yeah, thanks very much. I'm Phil Bourne. I'm the founding dean of the School of Data Science at the University of Virginia. I was also, I guess, was the ads, but effectively the first chief data officer of NIH. So Alicia, it's good to see you again. It's been a while. I found both of your presentations incredibly, I think Michelle said, inspirational, actually. There is a lot to do. And that sort of brings me to the thought I had around, it's really based in supply and demand. That what I'm seeing in academia right now is something I've never seen in 40 years, where the number of undergraduate students in our classes wanting to do some form of data science. I mean, we literally have to lock the door to keep them out. There's just this huge interest in this field. And of course, there are hundreds now of data science initiatives in virtually every academic institution in the country, mostly at the master's and undergraduate level, but increasingly PhD. The point I was going to make, and the seed I'd like to sow, is the idea of how you could utilize these folks. I mean, there's a huge emphasis from these people in data science for societal benefit, of which, of course, you're working in two highly overlapping areas, which is so important. I think, and the end result of that at the undergraduate level, those people then become inspired to go on and do careers that are really going to have some influence. So I think I don't know how you go about creating funding mechanisms that encourage this kind of thing. I mean, we're doing, if I just take us as an example, we're doing a lot of this, but the capstones that the students do are predominantly done with industry. And it would be good if there was a mechanism to actually have all these students working on these projects with, your agencies that are obviously trying to do much more than is possible to do. So that was just the thought.
Well, I can comment briefly. Our institute is probably not the most robust portfolio in this area. So, but there are lots of activities, and I'm trying to promote it, as you heard. I do think I think it's called Nimhd, right? The program to build capacity at under-resourced institutions, including HBCUs, is launched, and at least the initial reviews are very positive. I know Howard is involved in that and with the funded project. So I think Phil it's a great suggestion. Probably we should talk to see how we can help facilitate that. A lot of it happens intramurally, and that's where I don't know what the capacity is because we could do the summer internship program and post-backs, and so there will be opportunities of that type. But I don't know, in the extramural program, it's more limited flexibility on that. But
I will reach out to you because I have a few ideas about how that could work, particularly with HBCUs, which is something we do in the summer.
Okay.
Arsenio, is there anything you want to add?
No, I think they covered it. I mean, as some people will gravitate towards this type of work, and I view these offices of climate change and health equity and environmental justice eventually, once we get them off the ground, as places where we can have those learning opportunities and work directly with communities, once we get started. So and I've also seen that, I used to teach law school, law class in Berkeley Law, and, the amount of other professions that are looking, if they're looking at, doing environmental justice legal work, for instance, they're really wanting to pick up the data side of that as well. And frankly, we've seen a great need of sort of science and data when it comes to like even the Office of Civil Rights Investigation, where you're trying to look at different data sources and compare, in this case, for a legal argument about discriminatory sort of acts. But in general, a lot of those lawyers don't know how to sort of utilize and work with that information.
Yeah, thanks, Arsenio. It sort of sounds like that circles back to this whole need for interdisciplinary and transdisciplinary collaboration. That, the more people you bring to it, the more might be able to happen in that space. Irva.
Hi, thanks. Yeah, thanks to both of you, Licio and Arsenio. And Arsenio, we might have crossed paths. I worked on the scientific review panel for the CARB for about 10 years. And yeah, and I'm at the, sorry, I'm supposed to introduce myself. So I'm at the University of California at Davis, and we have a core center and other activities. It's really interesting. It was really great to hear your talk, and it seems like there's a lot of aspects of what California has done that are now happening at the federal level. I mean, even Justice 40, when you first put that up, I thought, my heart sort of sank, because I thought, oh no, they've got some goal for 2040, and that's way too far out. And I was really glad if that's not what it was. It was actually 40%, which actually ups what the California regulation has been, which is 25% of the appropriations should go for disadvantaged communities based on, the Cal Enviro screen. So this is upping the ante, which is great. And then I was really liking the questions, Michelle, that you put up. And the one that I guess really drew my attention was the second one about how do we advance the science on structural level interventions? Because that, to me, that the Justice 40 is that structural high level intervention. And I'm still, not entirely convinced that, what we're doing so far is really working yet in California with our 25%. Although, that's and by the way, the Imperial Valley thing, I did not know that was the origin of that, but really in the last 2 or 3 years, we've just seen an absolute explosion of this kind of citizen science with the purple air monitors everywhere, and really changing the nature and extent and density of our air pollution monitoring. It's just phenomenal. And then, of course, some of that is being funded through some of the state legislation, although some of it's just happening anyway, with communities stepping in because it's cheap, these monitors. So, but in terms of the science of knowing what's working and what's not working, what do you have ideas about how we? It just seems obvious that these are good things to do, but metrics and how you measure impact, and how you even study impact seems really important.
I'm afraid I don't know all the names on this, but I'll just be frank. I just got off the phone with the White House about this so-called, whether or not a lot of these investments that we're making are actually having the types of benefits that we seek. Health benefits, economic benefits, and they are admitting that they're a little bit behind on this. And so for Justice 40, I think, it's going to be tough. I was part of the whole thing in California, and even there we had a lot more time. And even there we failed, I thought, on, understanding health impacts for a lot of the programming and other things. I don't know what's working as far as, interventions. If you look at the California model, there are certain things that seem to be some of the things that Eliseo was mentioning about when you look at a community of safety and housing and these different things. One project was the Transformative Climate Communities, that the program was designed to look at a community as a whole and not just like these various programs that were available and just smushed together. And that program, UCLA Luskin Center did do an evaluation of that program, and where it got high marks was real public participation. They did participatory budgeting, which is unheard of in most governmental processes. The focus on housing and transportation, active transportation in particularly, led to sort of at least some, general feedback of safety, becoming, at least from the community's perspective, higher. And economic security, and many of these homes that were built were affordable housing with solar and battery. So not only do you have a safe place, an affordable place to live, but you don't have an electrical bill. And if you talk to most people, that having those three things, a safe place to live, some transportation options, and no electrical bill, they would say that's pretty transformative. And so they have some studies that were done, and evaluations. I would look at those from the Luskin Center at UCLA. But to be honest, we don't, I think, as you said, we don't know yet some of these programs. I do know that at the very minimum, any sort of interventions that are enforcement related should be happening. And so this Lowndes County example is a good example. Like, there should be no reason that that's gone on for 30 or for 3 decades or more, probably a lot longer. And there's a funding gap there, intervention gap. There's also an enforcement gap there. And so I don't know, I think those projects that are sort of, or those interventions that are not completely baked, but open to sort of flexibilities, those seem to be the projects that are working better. The other projects that are just spreading programs like peanut butter across an area and have no rhyme or reason to them, that's where you end up. You're from UC Davis, where in my community, they say, yeah, we invested $20 million in your project, in your extension track. Well, that's great. What were the benefits from that? And a farmer got, no disrespect to the farmer, I know the farmer, but he got like $20 million for drip irrigation. Now on the whole, is that good? Yes. Does that really benefit that community in a really transformative way? Probably not. And so, there's going to have to be, a lot more thoughtful, but you have to try. That's the thing, is you have to try these interventions, or else we'll just be stuck in neutral. And so that's the hope of Justice 40. That's, like you said, in California, what we're trying to do. Here at HHS, I would say finally that we are looking at that already from a climate and EJ lens. What are the obligations of health systems as it relates to housing? We know about community benefits and assessments, but what are some other things that they could be doing, as Eliseo was mentioning, to take a sort of a responsibility of the community at large in and around their area?
I think, Irva, the question was really focused on a lot on the second one that Michelle listed, right? A sort of science of structural interventions. How do you measure this? Most scientists who have looked at sort of these macro structural issues have really focused on population data. So linking census data with, in the EHS world, it would be, all the data we have now on temperature variation or particulate matter concentration. How do you link that up across? And this is where scientists, data science becomes so important with health outcomes related to whether it be COVID in one case or cancer or cardiovascular events within a health system, even using the electronic health records. So I think those are the approaches that seem most okay. We know how to do this. It's some money and will and scientists to really focus on it and get collaboration across. But that's descriptive. That's sort of pointing to where the problem is. How do we intervene is an unknown. A lot of the people I hang out with or talk to outside of NIH, think that we got to start with some healthy community models. It doesn't mean a whole city or whole town, but it could be even a neighborhood within a large city or a defined neighborhood where you create a lot more things at the micro level. Where people feel safe and definitely have more relations among each other, where there's access to food and there are ideally some economic opportunities in terms of jobs, and I think that's a harder one to get at, and linking that to health. And having health care settings begin to see that as part of their domain, as Arsenio was implying, healthcare systems that really manage a lot of resources. People need to know where to go when they have a problem, and they can't all go to Hopkins. If they live in this area, so you need good community clinics or community clinics that can manage this and be easy and friendly and high quality. And so those are you can't do it all. So you're thinking about interventions of those types that help promote improvement in structural challenges. Linking that to NAEHS priorities, will probably be more at this point on potentially on the macro level. But you can imagine part of making a community healthier is making whether it be solar panels or cleaner or access to green space be components that would be supported. So I think that this is with that direction that we're trying to see whether this common fund program moves in. And no one institute I think can do all of this. I think we can try in different components, and there's no reason not to start small. It doesn't all have to be one giant thing. So I remain optimistic that we have the tools and we can make a difference, but we need to start demonstrating it. And the old saying is, we scientists, we live on data, and that's what moves us. Policy changes on stories, and we got to build stories.
Thanks, Alicio. Jenny.
Hi, thank you, and Yate. I'm Janny Ingram from Northern Arizona University, Regents professor in chemistry, as well as a member of the Navajo Nation. And so great presentations. And so my question sort of revolves around the establishment of this environmental justice index and more accessing or having access for communities then to see this. So it helps them to say, we have problems and now, we can see this, but then how can we as NIEHS, as a scientific community, work to establish partnerships between a community and people who can actually, go in and investigate these things and provide the data for these communities to then say, someone needs to help us clean this up. And I'm just thinking about, I mostly work in tribal communities. So some of them, so Navajo is huge compared to most other tribal communities. So some of the smaller communities have major issues that you mentioned, the Imperial Valley, and just on the other side is 2 tribal communities that it's just horrendous down there. We're starting a project with one of them, but is how to make those connections. And then going to Bill's point, students are very interested in trying to go back and help their communities, and they are the connection to the communities. So trying to also pull in those students, but really, begin to build those partnerships. And I think these tools you talked about could be really useful. But how, I was thinking as people were talking that perhaps trying to make these tools available and really connecting with some of the grassroots groups in these different communities, because those are the folks that are trying to, say there is a problem, someone needs to help us, how can we establish this? But is there any vision for once, this index and, the cumulative exposure, because that's also a really important, I think, aspect of these things. These tools become a reality for the communities, and then the partnerships building with folks that can actually help them to address some of these problems, or at least get the data to be able to say, this is in your specific community, here are these exposures. So that's my question.
Yeah, I guess talking about the tool, I've now seen this manifest because I was leading the development in California for Cal virus screen. And, looking back at my childhood, like my folks didn't have that printout saying like, no, look, here's PM 2.5. We're in the 99th percentile compared to every other census tract in the state of California. Hopefully, this tool will help do the same for the corners of the nation that don't have all these other, as I said, universities or other resources to say. And they could say, look, I don't care how it's stacked, I'm here, I'm sitting at the top when it comes to asthma, when you compare every census tract in the nation. So let's talk about that. I think that information, accessible, available to everyone in languages that they can understand, which we'll eventually get to, is important to get the dialogue going, because in the, now, community members or others are coming, and it's not them saying it, it's the federal government saying it. And so that's an important power, dynamic that is important. I think, down the road, there will have to be a series of, sort of trainings for community members, tribes to understand the data. And I shouldn't sugarcoat the idea that any national data set, there are data problems, and this with tribal governments and territories and other things where it's not perfect, but we gotta start somewhere. But I do envision we did training courses, whole modules. If you look at Cal virus screen, I am the introduction to the training module there, where we walk people through the understanding the data. And it actually has turned out, really well in California. We wove it into not just policy, but when the secretary was the attorney general, we would weave it into our legal arguments, and people would say, well, why are you, taking this case? And then we would rifle off the data. It's the 99th percentile for X, Y, and Z. Cumulatively speaking, it's in the worst in the state. That's why we're here. Now let's get to the solution. And so, again, it's like the start to prioritization, the start to a conversation, and that's what we hope to do. But the last point about how do we put it into action, some of the work that through the, and forgive me, Liam, if I'm getting the name wrong, but the research to action projects, I go to these meetings, and, NAEHS, provides the structure for the funding of that project. And then the groups are carrying on those activities, the action piece of which they are getting results. And so, I would encourage you all to sit in on some of those. I'm not, Liam, I hope I'm not getting you in trouble, but I would encourage you all to sit in on some of those meetings, because you would see how that is happening within a program at NAEHS. Do we need to do more? Yes. And I would say with LSAO, made a very good point about you have to start somewhere at a little bit more on a smaller scale to work in, trying to work everywhere, it's not going to work. Sorry. That's it.
Yeah, no, thanks. And I've actually been on 2 of those research to action projects. So, and the partnerships with the community are just so important.
That's the only word I would add, is this embracing this community engagement model or platform at the start. If we want to have impact, if we want to have movement, we need to get partnership set up. That's what we hope we begin to accomplish with SEAL, but it's not the only, it can't do everything. So I think, we look forward to seeing more of these established in order to really influence. And I think the experience with American Indian and Alaska Native communities is really re-emphasize that for a variety of reasons. And it's really important. So I'm glad that your own experience reflects that, Jen. So.
Thank you.
Terry, I see your hand up next.
Thank you, Michelle. I'm Terry Kavanaugh. I'm a professor emeritus at the University of Washington, where I'm associate director of our center here. So thank you very much to both of you, Lucille and Arsenio, for the great presentations. My question is kind of more of a philosophical one in some ways. It has to do with what might be. So first of all, I want to backtrack and say that I really appreciate the notion of going from local to regional all the way up the chain, because to deal with things as examples, for instance, of those areas that are most heavily affected and prioritized is an important use case that people will be looking forward to evaluating the success of these programs. So one of the things I'm wondering about has to do, what are some of the major impediments to seeing those successes more broadly embraced and put into action in other areas. And I'm thinking particularly in the area of political science and the natural questions that come up with respect to things like the move recently for many state legislatures to, in their redistricting efforts, to gerrymander and to diminish the impact of minority communities in local decision making, and whether or not the Institute should be partnering more with those organizations, either at the federal level or state level, that actually have to do with these aspects of empowerment for political empowerment, and particularly demographers and political scientists who can maybe hope to direct these things. And ultimately, it comes down to the courts, as you know, that ultimately a lot of this is decided in the courts. And so that brings up the notion of environmental law and educating judges with respect to environmental health literacy. So just your thoughts on this.
Well, starting with the last one, I think, that was about the education and the work in the courts. The secretary and I, we created the first Environmental Justice Bureau for environmental justice. Attorneys who were solely, environmental law attorneys who were solely focused on environmental justice. That was their job. And if you take a look at what they've been able to do now, it's quite remarkable. The power issue, I would say that, just taking a step back and looking at from an environmental justice, speaking for environmental justice, environmental health, even for health and like inequity, it's the dynamics have shifted quite a bit in California, but also to the rest of the nation. And the rest of the nation is slowly coming on, where before, a lot of the environmental sort of policy makers and decision makers were the typical enviros, the big environmental organizations, Sierra Clubs, NRDCs, those people who controlled the policy. And in California, that's been turned on its head. So the power, now those folks are taking the backseat, and the people who have social justice or environmental justice in their sort of mission are really leading the policy stuff. So that's caused the politics to reflect that a bit. And I think ultimately maybe 10 years now down the road, the same will be said for the rest of the nation, where the justice and the equity folks, it's a power shift, and it gets flipped on its head. So I don't know, Alessio, if you had anything, but I just think that shift is coming, and it was quite remarkable to see that transition, because once the shift was on, the policies were, of course, the laws were now better reflecting, some of the issues that people were facing on the ground. And that's no surprise that now when you have organizations in power that are more close to those folks, that the legislation reflects it. And today in California, at least, you will not see a climate policy without a justice or equity provision in it. You won't see it. And so that's an example of the power shift in the sale.
Well, I'll say that, there are restrictions on what NIH can do in terms of policy interventions, and lobbying and all that kind of stuff. So we have to be careful. But one of the out of the box things is that, the local jurisdictions, particularly local government, I think should be partners in some of these structural interventions that we're referring to. And there's no real limitation at that level from our perspective as a federal agency. So I do think that's where there could be opportunity. And then the other comment is that we do fund not just in MHC, but multiple institutes fund policy evaluations or research on changes in policy that then have perhaps unintended good or not good consequences on health. And I think this is something that we routinely do try to look for or look for scientists who submit those applications. So, and Rick, I'm going to have to sign off in a minute. So.
Right. So I just got your note, and Michelle, I'm wondering whether we might want to bring things to closure here, since a number of people probably have 3 o'clock Zooms that they need to prepare for. But Elisa, before you leave, again, thank you very much. A terrific presentation, and thanks for staying on to answer a few questions. Okay, back to Michelle.
Yeah, I thought maybe we'd give Trevor, he's been very patient. I thought maybe we'd give him a chance to ask his question, and then certainly we can let everybody go. So Trevor, what's on your mind?
Thank you very much. So I'm Trevor Penning. I'm a P30 Center Director at the University of Pennsylvania. I'm a professor of pharmacology. And I was delighted, like everybody, to hear that Health and Human Services is going to have this new Office of Environmental Justice. And sometimes it's easy to get carried away with the new things on the block. And this is certainly very much needed. However, what I wanted to come back to was Superfund. At the end of the day, we all know that many of the Superfund sites in this country are juxtaposed in proximity to EJ communities. And in terms of Superfund cleanup, is that circular legislation is totally underfunded in terms of the number of problems we have. I'm wondering whether the new Office of Environmental Justice is going to put some of its money into help clean up some of these Superfund sites. And I also know when Rick gave his talk yesterday that the Superfund research budget for NAEHS has only increased by a measly $1 million. This is, kind of bizarre considering the issues we're dealing with, and these are right on our doorstep. In my state of Pennsylvania, we have 95 Superfund sites, and we have 45 in the immediate Philadelphia area. And this is where we need to start thinking about affecting these environmental justice communities by cleaning up the hazards we already know that exist. So that's a comment.
So just to clarify, it increased by 1.23% versus the NIH average increase of 3.4. So there's a differential increase. So
I can wrap this up real quickly. No, we're not going to fund it because, as you know, the cost on that, this office doesn't even have a budget yet. So we're not going to fund Superfund cleanup. 2, I would say we are working with EPA and HUD to look at, again, local efforts where HHS could bring something to the table to address, whether it's through health services or human services, the communities that are affected, as you say, by Superfund sites. But as you know, these are some sites are 1,000-year cleanup. It's a long haul. I agree with you that we need more money for Superfund site. I think our ability will be to work around the site as it gets remediated to see what more we could bring to the table from HHS to help those communities. Those same communities have other, issues. If it's, one was a lead site and, we could have lead screening, or we could do, there are other things that we could do around that don't require remediation, so to speak, or monies for that, because, that would take up a lot of our budgets. But yeah.
Well, I
Agreed.
wasn't thinking that we should clean them all up, but I was thinking because everyone knows that the problem is so huge that we would not have money to do it all. But there should be some effort into prioritizing the most hazardous sites.
Yeah, I'm on EP. I don't want to get ahead of myself on this, but there is an effort underway with HUD, HHS, and EPA on that, and we're going through the prioritization right now to look at those sites. But you're right, you're spot on.
Thanks, Arsenio. I think that was Arsenio's tip number 2, to prioritize. Rick, you have your hand up.
Yeah, I'll just make a quick comment here, kind of building on the same theme that Trevor is raising. When I'm in front of environmental justice communities, there are many of them are commenting to me that they've been to the director of the NAEHS many times. They're telling me, they told the previous director, the director before that, they want their communities cleaned up. Okay, it's nice to do research, but they want it cleaned up. So Arsenio, the question is, how can we be joining forces with other agencies of the federal government who have the responsibilities for cleanup? And so that we can be getting in front of the community, environmental justice communities, not just as research organizations, but also as kind of joint groups that we can kind of address their concerns from research to cleanup. I don't know, what are your thoughts on that?
I don't know. That's you guys tell me. What if you're not cleaning it up? What type of information could you all help? They clearly are saying we don't want any more information, but there is life after a cleanup or at different phases of cleanup. For those that are close to cleanup, the next question is, well, what's going to be there? I don't know if there's, you want to think of these cleanups as in phases. I just, unfortunately, if you want to talk about depressing, Trevor just took us and Rick to the most depressing part of environmental justice is the legacy cleanup, because if you look at the timelines on some of these cleanup projects, I've seen ones that are 1,000 years. And so it's, I don't know, it's a good question. I would want you all to think about. I don't know the full suite of what you all may happen. A lot of times I know when there's a cleanup going on, there's a lot of concerns around, the containment or the remedial management plans or whatever, the plans in place to mitigate, is, dust flying everywhere. I would go to sites that they would tell me, the site is secure, and I would go out there and I see wind, as the community members were telling me, carrying, soil that was likely lead, contaminated soil off the site, not contained, next to a school. And so there, the community wanted to put together, again, like some of these research projects to where they wanted to better understand that it's something that the government should be doing. But I don't know, Rick, that's really, that's really up to, NIHS to think more about. If it's not research, I don't know what other tools you all have in your box that could address that. But you're spot on. Those folks, want it cleaned up. The chances are it's highly likely that that's not the only thing in that community that is going on there.
Yeah,
that's why I mentioned the cumulative impact. So, sometimes you're not able to directly impact the cleanup. It's very bureaucratic. The processes are long, and and lose community interest because they're almost designed to lose interest. And so it's hard to keep community support on those things, but there may be other issues that are related, as I mentioned, like the project that we're working on with HUD and EPA, where you may be able to work around the cleanup site in a more meaningful way, and not just like a research sort of aspect. But that's a good question to think about. Let's pick a site and let's see. Let me come back to you guys with the site. Tell you what, there's a site, there's a super fun site in Birmingham, Alabama on 35th Street. That's a former lead site next to, one of the most socially vulnerable areas in Birmingham. I could give you the coordinates of that and the information on that. It'd be interesting to see what your team thinks about, like what could be done given the tools you have around that site. That would help us in our project that we're calling Reclaim with EPA and HUD.
Sounds good. Well, we have a working group that's going to be building some suggestions on what we can be doing on this front.
Good.
So we'll keep you posted. Michelle, I think we're just about ready to close out here.
Yep, I think so too. And so Arsenio, again, thanks for hanging out with us to the very end. Really appreciate it. And I think you just laid the foundation for some next meetings, which sound really exciting. So I think I just want to pull a couple of threads before I turn it back over to Pat or Rick, whoever closes out the meeting, but just want to reflect very quickly a couple of the things that I heard that I think are really important. The notion about data science and big data, not just for tomorrow, but also for today and educating the next generation of leaders in this area. I think a lot about implementation science. I think that's a theme that kept coming up, involving others at all different levels, everybody from the community to demographers to lawyers and judges. The notion of community health was also one that was really important beyond individual health. We need to develop and share more tools so that everybody can be involved. And Trevor's last point about don't forget all of the things that still need to be done as we move forward. So I want to thank everybody for a very robust and terrific conversation. And I think this was one of the best sessions of the council. So thank you. Back over to you, Pat or Rick.
I guess, Pat, if you don't mind, I'll take it up and close out the meeting. And I'll do that by, well, first of all, thanking Michelle for an excellent facilitation. And it was a very engaging and interactive session, as was the last time Michelle facilitated a discussion with council. So Pat, any other comments you want to make before I officially pound the gavel and bring us into closure?
Yeah, yes, thank you. I just want to note that there have been a lot of things put into the chat in the last few minutes, so make sure you check that. And I always like to save these before I go off. Like Rick said, I want to thank the presenters, and Michelle, I want to thank you for that, for moderating that and for agreeing to do it. You did a great job as usual. And as usual, I need to thank the people who made the meeting happen. So predominantly Liz McNair, who this wouldn't run without her, with a lot of help from Rose Moody, as well as some people from the administrative office, Katie McGinnis or Joel Collinson. And of course, the people who did the IT and the AV stuff, Nathan Mitchner and John Maruka. And then our science writer is Ernie Hood. So when you see these minutes and vote on those every time, those are generally written by Ernie. So he does a great job too. So I just want to thank all those people. Thanks, Rick.
Okay, terrific. Well, thank you, Pat. And I'll take my virtual gavel and bang, bang, bang. Council is now officially adjourned. Thanks, everyone.